Good afternoon, everyone. It is just gone midday. Welcome and thank you for attending our 8th National Clinical Pathways webinar. My name is Stuart Sutton. I'm a GP in Paisley and clinical lead for primary care secondary care interface, and I'll be hosting the session today, and we'll have the opportunity for some questions and answers at the end. The webinars are designed to showcase pathways developed by CfSD in collaboration with clinical communities and to provide a forum for education, informal discussions and a Q&A. As you can see on the slide here, we're going to record the webinar today and it will be available after the session. If possible, if you could use the Q&A button at the top there, so that's on that top bar, so it's next to the chat. If you could put questions in there, that will allow us to then to go through those at the end and ask the speakers for feedback or any advice. Today's webinar relates to lower limb disease with particular focus on chronic limb-threatening ischemia and venous leg ulcer pathways. And without further ado, I'm going to hand over to Graeme Guthrie, who is our Vascular Specialist Delivery Group clinical lead. So over to you, Graeme.
Good afternoon, everybody, and thank you for coming along. It's the 8th webinar, but it's the first vascular webinar, which is great. We have an accomplished group of people to hopefully educate you on some lower limb disease pathways today, and we'll just go through things as they come up. CfSD, as Stuart's already touched on, has produced a number of pathways, and within vascular, the current live set includes aneurysm, carotid endarterectomy, intermittent claudication, venous leg ulcers, and CLTI. We're only going to touch on the venous leg ulcer pathway and chronic limb-threatening ischemia today, but hopefully in the future, if this goes well, then we can develop that further. The plan for today, just so you're all aware and can get your timings, we will move forward first with the venous disease pathway. Mr. Siddiqui, who is a consultant vascular surgeon, also the training program director in Scotland for vascular surgery, and a very accomplished venous expert, is going to talk about the background to venous disease. We have Ailsa Herron, who is a vascular specialist nurse who is very experienced from NHS Tayside, who's going to talk around the pathway itself. And then Mr. Siddiqui will return again to talk about some of the interventions that we can offer. With regard to arterial insufficiency, we're going to talk about chronic limb ischemia pathway, or CLTI is more commonly known now. My colleague Mr. Sutty, who is a consultant vascular surgeon in Tayside and also obviously a clinical director there as well, will talk through that. And then, as I say, Q&A can be placed during the session and we'll try to address any questions at the end. So without further ado, we'll move on to Mr. Siddiqui.
So good afternoon, everyone. So thank you for the introduction, Graeme. So as Graeme said, I'm Tamim Siddiqui. I am a consultant vascular surgeon at University Hospital here, Myers, and I'm going to present to you the background in the venous leg ulcer pathway. And then I'll pass over to Ailsa Herron, who's a vascular specialist nurse at NHS Tayside, to go into a bit more detail about the logistics and components of the pathway. And then lastly, I'll talk about some of the interventions that we can offer for patients from a vascular surgery perspective with venous leg ulcers. So the reason for the focus on venous leg ulcers are because they are very, very important. And they're an area that for many years have been undertreated, often further down the list of clinical priorities in a lot of pathologies, but certainly very important and very morbid. So venous leg ulcers are the most common type of lower limb ulceration. And the prevalence in the population is 0.1 to 0.3%. And the problem with venous leg ulcers is they have a continuous cycle of healing and recurrence, and this poses and imposes significant morbidity on patients and impact on the quality of life, often taking 6 months to heal with associated time off work and significant usage of resources, both in primary and second care, with some estimates of between £1,500 to almost £6,000 per patient per year in terms of the cost to the NHS of these patients with venous leg ulcers. There's also good data that suggests that healing rates in the community are low compared to specialist clinics. Plus, there is recent evidence from a number of trials that indicates that early endovenous interventions, which I'll go into a bit more detail later on, can result in improved healing and reduced recurrence in this problematic group of patients. So the venous leg ulcer pathway was devised to streamline the process of assessment, specialist review, referral, and ultimately treatment with a view to finding a durable solution to these patients where we can not only speed up the healing of these patients, but also hopefully reduce recurrence. So what I'm going to do now is pass over to Ailsa Herron, who's a specialist nurse at NHS Tayside, who's going to go into a bit more detail about the pathway.
Thanks, Tam. So my name's Ailsa. I work in NHS Tayside as a vascular specialist nurse, and like Tam saying, I'm just going to go over the pathway and hopefully provide just a little bit more information so it's a bit clearer, and that's it really. So the pathway is essentially broken down into three components. The first part of it is just talking about referrals to the community venous leg ulcer clinics, which are managed in primary care, and where these referrals can come from. So primary care, your GPs and practice nurses, community nurses, which would be the district nurses, and other community specialists, so tissue viability perhaps, or podiatrists if they're seeing patients that have leg ulcers. And then there's also secondary care teams as well, so dermatology clinics, vascular clinics as well. Of course, at any step of the process and the assessment of patients, any red flag symptoms, so any acute infections, increase in unilateral erythema, swelling, pus, pain or heat, signs of sepsis, any acute or suspected CLTI, any suspected deep vein thrombosis, suspected malignancies, or bleeding varicose veins. These are all red flag symptoms. They should not be referred to the community leg ulcer service and should be referred to specialist, the relevant clinical specialist or service for more of an assessment. So the criteria for referring to the leg ulcer clinics, venous ulcers that have been present for 4 weeks or more in non-housebound patients. Chronic venous leg ulcer, just a short definition there. It's an open lesion between the knee and ankle joint that remains unhealed for at least 4 weeks and occurs in the presence of venous disease, typically in the gated area around the malleoli. So anybody that should not be referred and should be referred for specialist input is any suspicions of malignancy, peripheral arterial disease, vasculitis, atypical distribution of ulcers, any suspected dermatitis or that's resistant to topical steroids. Again, housebound patients should be referred to district nurses for assessment and treatment, and then any non-healing ulcers that have been getting appropriately treated for over 12 weeks. So the community venous leg ulcer clinic, the kind of setup they should have, this is probably the most, where I'm going to talk the most, should obviously be staffed by registered nurses, appropriately trained, but not necessarily specialist nurses. In a community setting, with appropriate equipment and appropriate facilities there. Ideally, you would want to have a low-level sink or equivalent, somewhere where you can immerse the legs completely. Washing and drying and even just kind of treatment of a dry skin with emollient is a really important part of good wound care as well. And then ideally somewhere that has got a bariatric trolley or split leg trolleys as well, just so nurses aren't having to bend over consistently. Patient assessment. So if you had a newer patient coming in, you'd want to put aside approximately 90 to 120 minute slots, which sounds a lot, but if you think you've got 2 legs, that is actually the time that's needed. The patient assessment is a fundamental element of the pathway that kind of goes alongside everything else, and we need really good, full, holistic nursing assessments to be taking place here. So this is why it's important that we have appropriately trained staff as well, so they know what they're looking for, they know what to be asking in terms of symptoms and assessment of the ulcer as well. the lack of appropriate assessment is something that leads to prolonged periods of ineffective treatment. So this is a really important part. It's also really important to set those expectations with your patient so they know what to expect, and maybe talk to them what they were thinking was going to happen. Let them know that it's probably going to be a period of months for healing and not just weeks. Reviewing comorbidities, asking about symptoms, medications, because all these things as well might give you information about why the ulcers aren't healing or what type of ulcers they are, and it might actually turn out that this isn't appropriate and they need to be referred for specialist care. And then assessment of looking at the legs themselves, just for looking for any signs of venous disease or any signs of arterial disease. Joint mobility is a good one to look at as well, particularly of the ankle. This is an important component of the calf muscle pump and is also needed for venous leg healing. It's also important to do a good assessment of the ulcer itself. This also supports your diagnosis and will also be able to give you any signs that specialist advice is needed. So you want to measure the ulcer, have an accurate clinical description of it, and also clinical photography if that is something you're able to get in your area. That'll also help monitor the progress of healing, and will also support a referral if needed. Used in conjunction with the medical history, physical assessment and clinical presentation of the ulcer is something that will help give everything a good assessment. Ankle brachial pressure indexes using the pressure cuff and handheld Doppler. Again, staff are going to need to take responsibility for this. They should be trained and competent, and the individuals are responsible to work within their competence as well. And this goes back to, again, having appropriately trained staff. We shouldn't be performing the ABPIs if we're suspecting a deep vein thrombosis. It might be painful for the patient, and it also might dislodge clot as well. If ABPIs are not able to be done at the clinic, they can be obtained later on and just get as soon as we can. So for the venous leg ulcers, you're looking for that ideal result between 0.8 and 1.3. And if you can't get the ABPIs, then, like I say, you can get them at a later date by referring to another service, and you can actually start first line low compression unless you have any suspicions at all that it might be arterial disease. We've talked about photography, and then also glycated hemoglobin tests as well is handy to get, just to help with the assessment. Discharge planning, you should start thinking 2 to 3 weeks in advance of the anticipated discharge. This just gives you time to get everything together. Sorry, I missed out the return patient. So for your return patient slots, you should probably be seeing the patients about twice a week, reducing to once per week as things heal, and carrying out another full assessment of the ulcer and any changes at each dressing change, so you can adjust your treatment plan as needed. So yeah, the discharge plan, and think of it in advance. That will help get all the relevant hosiery, applicators, etc. ordered for your patient. Also giving the patient and their carers some good information, possibly written information, just about how to don and doff their treatments, and then giving them some contact information with a 6-week open appointment that they can come back if they have any concerns in the future there. So thinking about then onward referral to a vascular one-stop clinic. Patients suitable for this, we've talked about the ABPI ranges there. Again, the patients need to be ambulant and physically able to attend. We've talked about the delays in obtaining ABPIs. You could consider implementing first-line reduced compression, except for those that have acute or suspected CLTI. If there is suspects of infection as well, we just refer to your local policies and manage these. And then if patients are referred to the vascular clinic, the compression therapy should continue throughout that surgical phase and should be managed in the community at the venous leg ulcer clinic. venous leg ulcers are not something that are predominantly managed by vascular specialist nurses. It's mostly arterial ulcers we have. Just an overview of things. So these are recommendations set out by the CfSD. It is designed now to ensure timely and standardized treatments for patients. It's produced in line with NICE guidelines, and there's also consideration to the ESHCAR and EVRA trials, which are really worth a read as well. They're really good. There is SOPs in the pathway they're included. There's one for the setting up the venous leg ulcer clinic. There's also one for performing ABPIs, and there is also one for the vascular one-stop clinic. Obviously, this pathway has been adapted from something similar we use in NHS Tayside, but it's really just intended as a guide for areas to develop their own services depending on what facilities they have available locally. At any point of the process, the referral to dermatology or vascular is always welcome. We're always here to provide support and advice to anybody that needs it. And thank you for listening. I'll pass you back now to Siddiqui, who's going to talk more about things.
Thank you very much, Ailsa. So I'm going to talk a bit about what happens when they're referred to the vascular clinic. So as Ailsa said, we're looking for patients with a venous leg ulcer with an ABPI 0.8 to 1.3. And these guidelines in terms of what happens next is in line with the ESHCAR and EVRA trials, which have shown that there is benefit in terms of not only reducing recurrence of venous ulcers, but also aiding healing if you treat the underlying venous disease. So patients who are referred will undergo a venous duplex ultrasound scan, and then the patient's results and patient will be reviewed by either the vascular surgeon or a nurse specialist, and then a treatment plan will be made to treat the venous disease. And the treatment modalities that we offer will often be endothermal techniques, which will be either radio frequency ablation or endovenous laser treatment. Could be ultrasound-guided foam sclerotherapy, and rarely we will perform open varicose vein surgery, although the numbers of open varicose vein surgery procedures are very small nowadays in light of the new developments we have. So when the patients are referred, what we're looking for is venous incompetence. In other words, reflux within the surface veins causing high pressure, further valvular destruction, which ultimately leads to the complications of venous disease. And the ultrasound scan will paint a picture like we have on the right-hand side, with the red indicating the refluxing veins. And this will help us decide what is the best management plan for these patients, because if we can treat the underlying superficial venous reflux, we can hopefully get venous healing. For example, this picture here shows that the saphenofemoral junction is incompetent with an incompetent great saphenous vein. Therefore, that's a patient that we would consider radio frequency ablation in conjunction with ultrasound-guided foam sclerotherapy to the branches, which I'll talk a wee bit later on. So I know it's a mixed audience we have of GPs, nurses, and also a vascular surgeon. And you'll all be aware that there was NICE guidance in 2013 that indicated that all patients with varicose veins should be referred to vascular services. So this was all comers, symptomatic, ulcers, no ulcers, pain, everything. So this opened floodgates to vascular services. So very quickly, Scottish Government produced guidance saying, no, this isn't the case at all. We need to be a bit more selective about who we treat. So our friend Catherine Calderwood produced guidance in 2019 saying that the only patients who we consider venous interventions for are patients with complications of varicose veins, and this includes the ones we're interested, patients with venous ulcers or healed venous ulcers. So in the past, you may have been aware of terms such as people saying, I had my veins stripped, or my veins were stripped out, or I had them divided. And these are old-fashioned operations that used to happen. So many years ago, if someone had varicose veins or venous ulcer, they either had nothing done at all, they were put in compression, or occasionally would have open surgery. But open surgery was a big operation, general anaesthetic, 10% risk of wound infection, high risks of nerve damage. Patients were off work for 2 to 3 months, high rates of recurrence. Often they didn't even get an ultrasound scan beforehand, and the results were fairly poor. So what we do nowadays are treatments like this. They're not done in an operating theatre. They're not done in a general anaesthetic. They are local anaesthetic, minimally invasive ambulatory treatments. So the treatment we do most commonly is radio frequency ablation, and this has completely replaced stripping of varicose veins. It's a local anaesthetic procedure that can be done in an operating theatre or a treatment room environment where the main surface vein in either the front of the leg or the back of the leg is cannulated, a wire is passed into the vein, and then a catheter is passed into the vein lined with anaesthetic fluid, and then energy is applied to that catheter, which heats the surface veins 120 degrees at 7 centimetre intervals and essentially destroys that surface vein, therefore stopping the reflux and therefore hopefully reducing the venous hypertension and causing healing of the ulceration. It's a local anaesthetic procedure. There are no wounds. It's ambulatory. Patients can return to work immediately. And there's good data that shows low recurrence rates. And this is a picture of a patient who's had RFA, who had a venous ulcer, has had their superficial venous incompetence treated, and the ulcer is subsequently healed. The other main treatment we do is ultrasound-guided foam sclerotherapy, and there's no doubt you've heard of this procedure or had documentation with this procedure mentioned. This is again performed in a treatment room environment, doesn't need an operating theatre, you don't need any anaesthetic at all. And essentially what you're doing is mixing a liquid sclerosant. So the sclerosant used is sodium tetrodocal sulfate. We mix that with air, which creates a foam, which is then injected via cannulae into the incompetent superficial veins. This causes an inflammatory reaction, which ultimately results in the veins being closed. It is quick, it's simple, it's effective, it's a treatment room procedure, very effective in ulcers, as it can often penetrate the small veins at the ulcer base. There are low recurrence rate and very good data showing that in combination with radio frequency ablation treating the incompetent main surface veins, it can be very effective in achieving ulcer healing. It can cause skin staining, it can cause phlebitis, and it does have about a 0.5% DVT risk. So it doesn't come without complications, and patients really need to be ambulant for this to be safe. If you've got someone who's got a big venous ulcer, who's essentially bedbound, first of all, they shouldn't be referred to this pathway, and second of all, they're at a high risk of developing deep vein thrombosis, so we'd be very careful about treating those patients. These are the main treatments we offer. We still occasionally do open surgery for varicose veins, very small numbers compared to in the past, and for specific indications such as saphenopharynx or very, very large surface veins, but the numbers are negligible, certainly in most centres in Scotland. So in summary, this is an overview of the pathway described both by Ailsa and myself in terms from the point of referral, community venous leg ulcer clinics, the vascular clinic, and ultimately treatment. And certainly this is something that I think will make a big difference to this very complex group of patients who I think for many years have been very much undertreated. Thank you very much.
Thank you very much, Tam. So my name's Stuart Sutty. I'm a consultant vascular surgeon in Tayside, and I've been asked to present the chronic limb-threatening ischemia pathway. Now, chronic limb-threatening ischemia used to be known as critical limb ischemia, and some of us still use that terminology, but we're trying to move on from it. So the pathway itself is set up based on national guidance produced by the Vascular Society of Great Britain and Ireland, because we recognised that there was a marked variation in practice throughout the United Kingdom in terms of getting the right patient to the right team at the right time. Now, lower limb disease is not considered the sexy aspect of vascular surgery, but unfortunately, it's the mainstay of our work in the vascular world. We're expecting an increase in about up to 70% of our workload is related to lower limb arterial disease over the next 10 to 15 years, and it's likely to continue. So it was based on, it's all in alignment with UK guidance. Some of the guidance is aspirational to give us something to strive for, particularly time to imaging and time to intervention. And we need to get, as I said, the right patients to the right team at the right time. So what is chronic limb-threatening ischemia? Well, it's part of peripheral artery disease. It's part of the spectrum. It's the far end, the terminal stage of that spectrum. As Graeme Guthrie alluded to earlier, there is a pathway for intermittent claudication. That intermittent claudication is the step before the chronic limb-threatening ischemia, but you can also have asymptomatic arterial disease, and a lot of elderly patients will have that out in the community. We're not really going to broach on intermittent claudication, but just to get one point across that intervening on patients for claudication does not prevent limb loss nor prevent progression to chronic limb-threatening ischemia. All we're doing is intervening for a quality of life. Okay, so how do we define chronic limb-threatening ischemia, or CLTI? It is a persistent pain, happens at night during the day. It's been going on for 2 weeks or more, and it's continuous, and it may be related with tissue loss, either ulceration or gangrene. The rest pain itself occurs in the most peripheral part of the limb, and that is the foot and the toes, not the buttock nor the thighs. We can also use some measurements to help guide us, and these are ankle brachial pressure indexes, or ABPIs, or toe pressures. And if you have a significantly low pressure, then in all likelihood it's going to be coming to the verge of chronic limb-threatening ischemia. But we do not use absolute pressures alone to make the diagnosis. It is a clinical diagnosis backed up by pressures. So the pathway itself, it's split into two. You can see along the top is the inpatient pathway. Patients are admitted, and along the bottom is the outpatient pathways with the time frames attached. Now, this was based on the slightly older version of the Vascular Society guidance, but the referral comes in, and here we have, it's going to be triaged by the on-call vascular team, or probably a better term would be an appropriate member of the team who's able to make that decision process. And we are guided by what exactly is in the referral document itself. And if we focus on the inpatient, if the person receiving that referral feels this really should be admission, we will get the patient admitted. One thing we have to make a clear distinction of, this is not talking about acute limb ischemia. That is a distinct pathology, completely separate from the chronic limb-threatening ischemia. If we deem there to be admitted, our goals are to get imaging and review within 48 hours. And that is full cross-sectional imaging, not just an arterial ultrasound scan or duplex, but a CT or MR. And we've got up to 5 days from the date of admission in which to get the patient treated, if we can. These are aspirational guidance. I think we'd be hard pushed to find many units in the UK able to achieve that. But everyone is now realizing this is the massive part of our workload. We can make a huge difference to a massive patient volume, and we really should be striving for these. The lower part of the pathway, we take the referral, we see it is urgent. There's a risk of limb threat, as in the pathology's name is limb-threatening ischemia. And we have 7 days, ideally, to see a specialist, get them to a clinic, and get the imaging done. And we have up to 14 days in which to instigate the treatment. One of the problems we're all faced in the NHS is a lack of resources, particularly in vascular surgery. We have very limited numbers, and everyone in the hospital is now fighting for CT scans, MRI scans, etc. But it's up to our teams locally to push for this, and we are making progress in it. Once we get the imaging, ideally, we have multidisciplinary team meetings. Now, they can be the formal meeting we have once a week, but with some of this pathology, we don't have a week to wait. So we might hold an informal meeting because we've all got different methods and different ideas about treating lower limb disease. And then ultimately, we intervene in the lower limb, hopefully with a limb salvage procedure. Unfortunately, a lot of our work, we are seeing very end-stage arterial disease. Some of the disease is not reconstructible, and by that I mean there's nothing we can do to improve the blood supply, ultimately to save the limb, and that can result in an amputation. An amputation shouldn't always be considered an evil thing. It can be a good thing. Return to patients with a pain-free, adequate quality of life with good rehabilitation teams. So where do the referrals come from? We take them from everyone. We take them from the community, accident emergency, podiatry, community nurses, and they all come through a central point in each unit. And the person doing the triage is trained to recognise the signs and the symptoms within the letter of the referral to put them into the streamline into the pathway. As we said, the omitted pathways for the extremely urgent ones where we feel there's imminent limb threat, and that is so we can control the imaging, control the intervention in a finite period of time. The outpatient pathway, we have a bit of time to play with, but we've got to remember the pathology is it's limb threatening. The longer we leave it, the more tissue loss, possibly the more intervention we need to do to establish limb salvage. A lot of the units now have established hot clinics or a form of this. And by this I mean we're keeping an outpatient clinic area, wherever it is in the hospital, ready to take some of these urgent referrals for chronic limb-threatening ischemia. Our practice in Tayside is we keep slots open in our vascular outpatient clinics for urgent referrals every week, so there's no delay in getting patients in. Some other units will have a bespoke hot clinic purely for these urgent referrals coming through from this pathway. In an ideal world, we'd have clinics running both hub and spoke. And what I mean by that is you might be aware the vascular surgery across the UK is centralising due to outcomes, and we really should be having major arterial hubs with the smaller spokes offering as much treatment as we can in all the different regions. And we really should be hosting these clinics in the local regions if possible. In an ideal fashion, a lot of the patients, most of them, in fact, all of them, really should be discussed at a multidisciplinary team meeting. And for us, that is a combination of vascular surgeons, interventional radiologists, vascular nurses, vascular medics, as well as anaesthetists as well. And that allows us a very robust conversation centered around that patient and the individual treatment plan. How do we need to do this? We need to have access to the appropriate treatment rooms for this. And you may have heard terms thrown around like a hybrid procedure or hybrid theatre. So very briefly, touching on intervention, we have a scope from endovascular. That means we are treating purely in a non-open manner, percutaneous within the vessels, either balloons, stents, we have drug-coated technology, we have lithotripsy. But it is within, it's percutaneous, minimally invasive, but it still can be an extensive procedure. We still rely heavily on open procedures such as endarterectomies, bypass surgery, amputations. And what we mean by hybrid is a combination of both. And what we've seen across the UK and the Western world over the last 10, 20 years, there's been a change to the spectrum of arterial disease that we're now seeing. And it's actually very rare for us to have an isolated endovascular procedure or an open procedure. We're usually combining the two in order to get limb salvage. And that might be something along the lines of a femoral endarterectomy. In other words, we're opening the groin, opening the artery in the groin, scraping out the significant disease, stitching on a new piece of artery, and combining that with stents either proximally in the aortoiliac segment or peripherally down the leg. Now, mentioned here, audit. The Vascular Society, we have something called the National Vascular Registry. This is a national audit. Unfortunately, it's not obligatory in Scotland, but every year we have the Scottish Vascular Meeting, which one of my colleagues here hosts, and we audit every unit's results. And we want to make sure that what we're doing is above board, there's no outliers, but also sharing different treatment strategies and plans. And it's important that we keep an eye on our limb salvage rates to make sure we have minimal variation, but also to share good practice. The MDT, the multidisciplinary team meeting, is now key to a lot of our decision-making process. The patients themselves are becoming more complex. They're elderly, they're frail, multi-morbid conditions. The treatments themselves are also becoming more complex. Treatments themselves, as I said, may involve hybrid working, a combination of endovascular surgeons, open surgeons, interventional radiologists, all striving together to get the same outcome of limb salvage. And these procedures can be quite extensive and quite time consuming as well. And it's important that we try and identify the right treatment strategy for the right patient, and we don't just rely on one individual surgeon's idea, because we're not always right. Intervention we touched on is a combination. Ultimately, we're looking to achieve limb salvage. It is not always possible. And then we have to have these open and frank discussions with the patients and their families that an amputation could be the only option. It could be the only option in terms of we cannot reconstruct the arteries. It could be the only option in terms of for sepsis control, or the only option because of the amount of tissue loss that is present in the limb, we will not be able to salvage that leg. And then it's important to involve the wider team, the rehabilitation team, at the earliest onset possible, in order to give the patients as much information as they can to get the best outcome. And as I said, we all have local governance procedures, audit, M&Ms, but nationally we have the Scottish Vascular meeting where we do touch upon every unit's results across the main domains. And for any sort of background reading, you've got the Getting It Right First Time report, and we've also got the Vascular Society's guidance as well. Thank you very much.
Thanks, Stuart. Thanks, Tam. Thanks, Ailsa. Really comprehensive coverage of the pathways that have been developed. Stuart Sutton, I don't know if you want to address the questions. There's a couple in this Q&A, and then I can ask the team to answer them.
Thanks very much. Yeah, that was great. Thank you, colleagues, for really interesting and informative talks. We've got 3 questions there. We've got a first one from Bernard Conway. Is ABPI cuff only asked for prior to referral to community venous leg ulcer clinics as part of that referral?
I can answer that, I guess. Tam and Ailsa could weigh in as well as if you see fit. I guess in an ideal world, ABPIs would be carried out partly to prevent what Ailsa describes as the pathways to prevent any delay. One of the difficulties with ABPIs is that there is a quality control issue. So sometimes it is better performed by someone who has experience of that. So in the pathway, it doesn't say before referral, it actually says at time of referral and first assessment. But obviously, if there's a good, well-controlled ABPI setup in the community prior to referral, that would obviously help the teams moving forward. And different areas will have different resources with different expertise. So I guess that's the answer. I don't know if Tam, you have anything different in Lanarkshire?
Same as you described.
Yeah.
Brilliant. Thanks very much. Question from Alan Meldrum. Thanks for all the pathway work. Could the CLTI section clarify that toe pressure less than 30 indicates severe ischemia, but that higher toe pressure with tissue loss or non-healing wounds may still warrant urgent vascular review, so thresholds are not interpreted as exclusion criteria?
Do you want me to answer that, Graeme?
Yeah.
So no, thanks, Alan. I think if you look at the pathways, the pressures themselves are not the be-all end-all. It really is a clinical diagnosis. But you are right, and you see it's touched upon in the venous pathway. We've got pressures of variation between 0.8 and 1.3. Higher pressures, it may just be as Alan's alluding to, the arteries are calcified, so it's giving us a falsely elevated reading. Hence, it really is a clinical diagnosis. But I've also seen people with very low pressures do not have limb-threatening ischemia, but have significant cardiac failure as well. So I think the hard and fast values, we've got to take them in the conjunction with the clinical picture. But Alan is right. And I think in the updated version, we may be broaching on that itself. So good point, Alan. Thank you.
Yeah, I mean, to clarify, all of these pathways, as you probably know, do go through a review process. The AAA one has recently gone through a review process. And so that will be something that we can consider, I guess, when we get to that review point for this pathway. So yeah, thanks, Alan.
Many thanks. And last question we've got there is around question around referring patients with with varicose veins. And I guess that's kind of probably alluding to the discussion that people with venous ulcers benefit from referral, but I think the advice remains that you kind of described there around kind of routine referrals for people without complications. Would that be correct?
Yes, so NICE indicated that we should refer patients with varicose veins, but then Scottish Government have clarified that the only patients who should be referred are those with complicated venous disease. So in other words, venous ulcers, varicose eczema, skin changes, bleeding, or recurrent episodes of superficial venous thrombosis. That's really the only criteria. We have automated systems. If we get referrals that don't meet those criteria, a letter goes back to the referrer indicating that it doesn't meet the government criteria. And I think that's similar for most health boards across Scotland. There's no data that's shown that varicose veins always get worse, so there's no indication or benefit in prophylactic treatment of varicose veins to stop ulceration or skin changes.
I think that the additional message about varicose veins as well, because we have had some experience locally here that there's a feeling in the community that varicose veins just aren't treated at all, and that's clearly not the case. And as Tam alludes to, the CMO guidance is pretty clear. The indications are very clear. So absolutely, in the direct answer to that question, yes, you should refer them, but they should be referred based on the CMO guidance, which is pretty straightforward.
Yeah, I think that's very helpful for GP referrers to have that clarity, because I think we do often see people presenting seeking referral who don't unfortunately fit the criteria, and I think being able to be really clear at the point of consultation is really helpful. Okay, we've got a final question. We currently treat, this is definitely not my wheelhouse, I'm afraid. We currently treat VV patients C4 or above. Should we change that to C5 now?
No, because C4B, C4A skin change are skin changes, so C4 is absolutely something we should be treating. C5 is ulceration, healed ulceration 6. So yeah, C4 definitely is what we should be treating. I think the Scottish Government CMO criteria has got lots of pictures and lots of annotations about what is defined as a skin change and not. So it's very, very useful for referrers.
Brilliant. Thank you very much. I think that is all of the questions we've got. I'll just give it another couple of seconds in case there's any more coming in, but it looks like that might be everything. So I think if there are any questions people want to ask out with the meeting, you can email the email address there that's on the screen. So cfsdmppp@nhs.scot, and we'll endeavour to get those answered for you as well. I think the main thing I need to do is to thank Graeme, Tam, Stuart and Ailsa for that fantastic presentation, and to colleagues for attending today. We have got one question I'm going to squeeze in just before the end then, which has just come in, which is there a critical timescale when ischemia becomes non-salvageable, and what differentiates acute critical ischemia from chronic? Snuck in there, so I'll hand that over to colleagues.
Just pulling out my textbook answer here. So it's acute limb ischemia, not acute critical limb ischemia. So acute limb ischemia is a sudden onset of ischemia or pain related to ischemia, i.e. within 2 weeks. And there'll be no background pathology such as claudication. Okay. To complicate matters, you can get acute on chronic. The patients might present with a long-standing history of claudication, pain on walking, i.e. it's intermittent claudication, with a sudden deterioration. And these patients are, notoriously difficult to treat. I can't see the full question there, so hopefully I've answered it.
Yeah, I think that sounds like that you have, absolutely. So it was what differentiates acute critical ischemia from chronic ischemia, and I think that's exactly what we've described there. So thank you. Okay, so just a reminder, please, if you could, it really helps us if you could either click the link or scan the QR code there for a feedback form. It just helps to inform future sessions and provide some feedback to both us as organising it and the speakers. We've got the link there to all of the webinars, both past, present and future. And just a reminder, we've got 2 further upcoming webinars. We've got severe asthma on the 18th of May, 5 till 6 p.m. And then we have got gynecology with a focus on endometriosis and postmenopausal causal bleeding pathways, and that's 3rd of June, also 5 till 6. So many thanks once again to all of you for attending and to our speakers, and we'll see you at the next session. Thank you.
Thanks, Stuart.
Thank you.
Thanks.
Thank you.